I'm Dr. Madhushani. I'm Senior Registrar in Psychiatry, currently working at Lady Ridgeway Hospital, Colombo. So today I'm going to discuss with you about obsessive compulsive disorder, one of the topics, not a very major one. But I think most of you are familiar with that. So then before starting my lecture, I thought of like there are about 16 students, it seems. So I thought of like sharing with you about this ERPM exam psychiatry component. So are you familiar with that? The current curriculum and about the exam? So it would be easy for me to conduct the lecture if you are interacting with me. So I hope that you will talk with me. So one is telling here, I don't know. Are you aware how many questions are there um, from psychiatry and how the marks are distributed? Hmm? Can you just, if you are reluctant, like talk, can you message, like put a message in the chat box to decide me whether to talk about it with you or not necessary? So one is telling not really. Okay. What about the others? They are about the other 15 students. The other one is telling also no, not. Okay. Okay, it seems that you are not that much aware about the current curriculum and the this distribution of marks. So you know that there are two parts in ERPM exam, ERPM part 1 and 2. Probably you have to know by now. So and ERPM part 1, there are 3 papers. So in the third paper, they have included psychiatry questions. So psychiatry questions, community medicine and forensic psychiatry, I think. So in psychiatry questions, there are true and false questions, as well as they have added this new component, single best answer questions. You might be familiar with the single best answer questions in your final exams in whichever the university that you have been learning and learned. So then the marks, like in this third paper, so they have included 15 true and false questions and 17 SBA questions. So it means like out of 50 true false MCQs, you will be getting 15 psychiatric questions, and out of 50 SBA questions, you will be getting 17 psychiatric questions. So that means roughly about 1/3 of your questions will be from psychiatry in paper 3. So the interesting point is that you have to pass like all 3 papers, paper 1, 2, 3, to pass the ERPM part 1 paper. So out of that, you have to get 50, like at least 50 for each paper. So that means psychiatry will be one of the important component in your exam. So then the other thing is like ERPM part 2. So when you pass the ERPM part 1, it means like you have got 50 marks for all 3 papers. Then you have to sit for go for this ERPM part 2, where there will be 20 OSCE stations. So there will be 1 psychiatry OSCE station out of that 20 OSCE stations. So that's how psychiatry will be important for your exam. So that I wanted to, like in very beginning, I would like to give that introduction to highlight, like especially in this part 1, the psychiatry will give you this 1/3 of marks. That's what I wanted to highlight. So it's better if you like, it will be good for you, like if you pay attention to psychiatry as well. Like usually at our times also, we thought of like psychiatry, it's not that much important. So we mainly concerned about the other major subjects like surgery, medicine, obs and pediatrics. But in your but it's important. Now we realize that how much it is important. Wherever you work, also in your career also, you will need this psychiatry. So after giving this, I think, eye-opening to your exams, so go and read about the current, the newest curriculum and be familiar, because when you are studying for the exam, so you have to study the exam. So that's what I learned from my experience sitting for all these exams. So study the exam uh, beforehand, so then it will be easy for you. So giving that sort of suggestion, I would like to start my current today presentation. So let me share my presentation. So sorry, actually my video is not working. That's a disadvantage. I will get it corrected for my next lecture. So can you see my slides?
Yes.
Okay. So when I go through the slides, if you are encountering any kind of question, you can stop me and ask. Otherwise, this will be boring because this time is 9 past. So if you are interacting, this will we can together make it interesting for you guys. So the topic today is obsessive compulsive disorder, or the OCD. So I have outlined my lecture. So what is this? Yeah. So yeah, like this. So I will be starting as a simple case scenario that I have encountered in my career. So then I will move on to the what is OCD and the diagnostic criteria, the epidemiology and the differential diagnosis, etiology, prognosis, and management of OCD, as well as I will briefly touch this obsessive compulsive related disorders, because I saw that when I go through your exam papers, they can come as like they have come as your MCQs. So that's why I thought of putting that brief overview about few OCD, obsessive compulsive related disorders as well. So let's move to the case scenario. So this case is about a 14-year-old boy was referred to psychiatry clinic from OPD due to decline in his school performance. Upon exploration, the boy reported to have recurrent, intrusive, unpleasant thoughts of getting contaminated with germs for the last 1 year duration. These thoughts have caused a significant distress in him, which in turn led to repeated hand washing, 4 times at once, about more than 10 times per day, and bathing for about 2 hours per day. As he was taking a quite lot of time to perform the above rituals, he could not attend to his studies as previous, which led to gradual decline of his school performance. However, he did not have symptoms of depression or any other anxiety disorders. His sister has had similar symptoms and she was on treatment. He was having perfectionist traits. So can somebody tell me about the key words that you can find in this case scenario that are related to this topic?
Repeated hand washing,
Yes, good.
mm, and bathing for 2 hours,
Sorry.
and bathing for 2 hours,
Yes, yes, good.
and about the rituals.
Yes. Yeah. What about that recurrent, intrusive, unpleasant thoughts of getting contaminated with germs?
Yes, that's
That's
also.
also important, no, for the last 1 year duration and posed a significant distress in him. We also get some sort of thoughts time to time, no? But we are not that much distressed about those thoughts, no? They are coming and going. But he is in severe distress because of these symptoms. That's important. As you mentioned, yeah, repeated hand washing, bathing for about 2 hours, and taking quite a lot of time to perform these, no? Like, yeah, time consuming, and his school performance has been deteriorated. And apart from that, I have mentioned there's no symptoms of depression or any other anxiety because it's important that I have mentioned. And sister also had a similar symptom, and he was having perfectionist traits. So those each and every key words are very important. Because these kind of case scenarios you can get in SBS, that single best answer questions. So then they will ask you what will be the most probable diagnosis kind of. So it's very important that you highlight the key words that they have mentioned. So keep in mind that case scenario when I go through the lecture that I will bring them one by one when they are important. So then, so let's move to talk about what is OCD. So it says in the definition, the OCD is a chronic, recurring neuropsychiatric disorder characterized by recurrent obsessional thoughts, plus or minus compulsive acts. Okay. What sort of disorders do you know in psychiatry? There are different categories of disorders. So, are you aware of any category of disorders? Like how you just categorize when you are learning? Anybody? Have you heard about psychotic disorders? Okay. Mood disorders? Probably you have heard like depression, bipolar affective disorder, psychotic disorders like schizophrenia, delusional disorders, schizoaffective disorders, so combination of mood and psychotic disorders. And there's a disorders called we categorize as neurotic disorders. So OCD falls under these neurotic disorders, OCD, anxiety disorders. Okay, there's a one sort of categorization. So there will be, it's a chronic, it's recurring, and there will be recurrent obsessional thoughts and compulsive acts. So we are going to discuss about what are these obsessional thoughts and what are these compulsions. So what is an obsession is? How you like define it or explain it? Okay. So obsessions are repetitive. It comes and comes, it comes like popping up again and again, intrusive, and they are very distressing to the patient. So, and also the patient knows they are inappropriate and senseless. And most importantly, they identify these thoughts are their own thoughts. Okay, I believe that you are familiar with this thought insertion, thought alienation in schizophrenia. So they don't be like, they think that someone is putting the thoughts to their mind. Okay, thought insertion, what we call. So there they think the thoughts are from others. But here, these people with OCD, they identify these obsessive thoughts are their own thoughts. Okay, that's how you differentiate from this thought insertion and these obsessions. So then the patient will resist these thoughts. That means like they will try to stop these thoughts popping up, but they fail to do so. They will come up with, when you are taking the history of this OCD patient, then they will tell you, I have tried my best to stop these thoughts, but they repeatedly coming up. So I mean severe distress. Then not only thoughts, okay? These repetitive nature, like these obsessions can be thoughts as well as they can come as images. Like, as I mentioned in the case scenario, it was what sort of thing, what kind of obsession was there in the scenario? Can anybody tell me? What was it? Is it a thought? Is it a doubt? Is it a impulse? What was there? Anybody? It's also mentioned it. It's mentioned there. It's a thought, no?
Washing,
Yeah.
washing has too much, like often, so
Okay.
often.
So I'll come to that later. It's a compulsion. But the obsession here is he is getting a recurrent, intrusive, unpleasant thought of getting contaminated with germs. So that's the obsession there. Okay, did you get that? So here the obsession is that the thought of getting contaminated with germs. Okay, so it's a thought. So some people with OCD, they will get these kind of thoughts. Some will get images. Like they will, I have seen patients with obsessive images, uh, like they are hitting somebody, like stabbing someone. So they see that as an image internally, not as a hallucination, which you see in outside of the uh, body, kind of external. But this is inside the memory, like the image. Like when you imagine something, you can sort of make a picture from your mind. Am I right? Like we tend to like imagine things, no? So like that, there will be an image within his brain, like within his mind. It's also coming recurrently, okay? Again and again. So those are very distressing to him, okay? Images. So some people see, I have seen people who are seeing smashing statues of Lord Buddha, okay? Like that. So they are very distressing because you being a religious person, you see these kind of, you are getting these kind of images. So it will be very distressing for those people. So those sort of things can happen in like the patients will have. So then impulses. Impulses means obsessional impulses. They feel like stabbing somebody, killing somebody, hurting somebody, kind of. So those impulses. And then there will be obsessional doubts. As an example, so will my one of the family members will encounter an accident today? Okay, likewise. So will I pass the exam or not? Though that kind of doubts can occur as an obsession. So they are recurrently like it will has this, it will have this, the first dot point that I have mentioned, the nature of the first dot point, like repetitive, intrusive, distressing, senseless, identified as their own kind of doubt. So likewise, thoughts, images, impulses, doubts, and they can have obsessional ruminations. Like they will argue themselves, okay? They debate inside themselves. They go on debating about one topic, likewise. Okay, we also tend to do that, but we are not that much distressed with that. No? So these patients, when they have these recurrent ruminative thoughts, that they will have a lot of distress. So then, as I mentioned, the themes, then in my case scenario, the theme was contamination, no? About dirt, germs. Then there could be religious themes, as I mentioned, like destroying Buddha statue, kind of religious themes could be there, as well as sexual themes. Like they might get thoughts about like sexual feelings towards a close family member, okay? Towards mother, I have seen patients having those thoughts, so they are in very distress. So those kind of themes you can see in these patients. And it says it's ego dystonic. These obsessions are ego dystonic. This is one of, I think, this can come as an MCQ question. Also, it's very kind of a favorite question. Ego dystonic means it's against. It's not keeping up with your values or beliefs. Okay? It's not keeping up with your ego. Okay? Are you clear about this? What is obsession? Are there any questions? Hello? Are there any questions regarding obsessions? You can ask. The chat. In the chat also you can.
No, ma'am, it's clear.
It's clear, no? Okay.
Yeah.
They're asking questions about, will you send the PDF after the class? I will ask about it. And thoughts, what's the difference between visual hallucinations and images of thoughts? Did you get the answer or do I need to clarify it? Jaya Rupan, do you want more clarification regarding a difference between hallucination and the obsessive images?
No, ma'am, I got it.
You got it, no?
Yeah.
Yeah. The hallucination is occurring externally, like it sees you as outside, that as you can see somebody else in the vicinity. Okay. But obsessive image, it's within your mind. You can see them externally. It comes as you imagine something when you see some mental images. So it pop-ups like that. Okay. It's internal. Okay. So then let's move to compulsions. So the next slide is about compulsions. Okay. It's going up there. Okay. So let's move to compulsion. So we have discussed what is obsession. So now we'll discuss about compulsions. So compulsion is a repetitive behavior or cognition performed according to certain rituals. So when you are getting these repetitive thoughts or images or any impulses, so then the behavior will be this ritual. So they will perform something to relieve the distress that they have with the obsession. So in my case scenario, I have mentioned because there was an obsession that he had been contaminated with germs. So he had been washing his hands repeatedly about 4 times once. Okay. So because this thought is very distressing, he performs some act to relieve his distress. That is a compulsion. Okay. Or bathing himself for about 2 hours to remove these germs. Okay. So that's a compulsion. Okay. So they might have some rituals. It means like when you're washing hand also, these patients will have like, I have to like, to remove all the germs, I have to at least wash my hand about four times. Okay, every time they wash hand, they will wash 4 times or even more in some patients. And they might have some patterns like first they wash with soap, then with hand wash, then again with Dettol. Okay, some patients will have this sort of behaviors. Okay, so likewise, when they are bathing also, they will wash first hands, then afterwards they move into the body, like chest and the lower part, kind of one leg by leg by leg. Some they will have some patterns. Not all patients, but some patients will have. So some are very complicated compulsions. Okay. So then because these compulsions are very excessive and they will also take a lot of time. Okay. Then in turn, after performing this will reduce the distress occurs with the obsession. So that's why they are doing it recurrently. They will do it again and again when they get these obsessions. Okay. So as an example, washing, cleaning, checking, some people will get the doubt that I have closed the door or not. Okay, then they go and check again. Usually we also do that, like once or twice, sometimes we do. But we are not distressed afterwards. But these people, they have to go and repeatedly check, and it comes frequently throughout the day. So flushing the toilet also same. Like whether I have flushed or not, like they go and check again and again several times. Okay, that is happening repeatedly. Okay, then some will have these counting rituals, as I have to do this 4 times. I have to count and do this much of time. Okay, I have seen very like complex ones, like even to go and bathe, like they will count the day, the time. Okay, they will calculate the numbers, and if it is if an odd number comes, they don't go and wash. Like there are very complicated cases. Okay, but for your level, like you have to know some basic idea, like counting rituals. And there will be like this, you can see, this from outside, like they go and wash hand, they go and occupy the bathroom for about 2 hours. Okay, then they will go and check whether the doors are closed or not, kind of. The other people can see. So we call them as overt compulsions. So these compulsions, these repeated behaviors can be seen by other people. But there will be the other type of compulsions are covert compulsions. So other people can't see. Suppose that you get recurrent doubt. Will my mother meet an accident today? So then you will chant some prayers inside your Itipiso, like they will chant Itipiso Gata. Kind of, they will do some, repeat something, but you can see from outside. Okay, this is a mental ritual. Okay, mental compulsion. These are covert. Okay, they can have like both. So, are you clear about compulsions? Hello?
Yes,
Are you
ma'am.
clear about the compulsions?
Yeah. Yes,
Yeah.
ma'am.
So they are linked to obsessions. Okay. So then we'll, if you're, as you are clear with this obsession and compulsions, we'll move to diagnostic criteria. So are you familiar with diagnostic criteria in psychiatry? How many diagnostic criteria usually we are using? How many diagnostic manuals? There are 2, okay? Like usually we use either DSM-5 or ICD-11. The current one is ICD-11. Used to use ICD-10. Now the newest one is ICD-11. So according to that diagnostic criteria, it says the OCD, obsessive compulsive disorder, characterized by the presence of persistent obsessions or compulsions, or most commonly both. Okay. And it says obsessions and compulsions must be time consuming, 1, or result in significant distress or significant impairment in areas of functioning. Okay, either education, social, occupation, okay, family. In my case, the case scenario that I have given, his school performance has been deteriorated. So he has significant impairment in his education. No? So, okay. So there are specifiers in this diagnostic criteria, like with insight. They talk about insight. There will be OCD with fair to good insight, OCD with poor to absent insight. Usually what we see, the most commonly we see is OCD with fair to good insight. So that they think that they are having a psychiatric, because these obsessions and compulsions occurs because of a psychiatric illness. And they are willing to, usually they are willing to take treatment also. Okay. So then we'll move to epidemiology. In obsessive compulsive disorder, the lifetime risk says about 2.1%, and female to male ratio is 1 to 1 in clinical. It's almost same in clinical populations. Okay, it can be different in different, like I have seen slightly different in some resource materials. But according to the short Oxford, that usually what we are using, it says it's almost similar. And childhood onset more common in males. These can come as your MCQs. That's important. So then let's go to differential diagnosis. So when a patient comes with OCD, so what are the other conditions that you have to think about? Okay, you have to think about anxiety disorders. I think you are familiar with anxiety disorders, the phobias. There could be social phobias, specific phobias like phobia to animals, height, those things, and panic disorder. Okay, other anxiety disorders. And you have to think about depressive disorder as well. Because when you get depressed, these obsessive OCD symptoms can escalate, okay, increase. Or OCD patients can have secondary depression. When the OCD is severe, then they can have secondary depression. Right? Because of that, they get depressed. So, and you have to think about the schizophrenia as well, because they are performing this repeated mental ritual, repeated acts, smart acts. So, we have to dig whether these are controlled by somebody else. Okay, you have to ask, right? So schizophrenia, and there will be some organic causes which cause OCD, like obsessive compulsive symptoms. I will be discussing about it in next slide. And we have to think about childhood onset disorders like Tourette, autism. I hope that you have heard about. Okay, so then, okay, differential diagnosis. Then let's move to etiology. So etiology, there will be genetic predisposition or the genetic contribution in these patients. So that is evident from that monozygotic twins, like the same twins kind of monozygotic twins will have this OCD more than the dizygotic twins. That means like there is genetic vulnerability is high. So then risk in first degree relatives, like if suppose that there's OCD patient and their first degree relatives are having fourfold risk of getting OCD. And there will be some neurotransmitters which are involved in this etiology, like glutamate, serotonin transporters, BDNF, okay, brain-derived neurotrophic factor. So those give evidence towards the genetic etiology, okay. Then there will be brain disorders like encephalitis lethargica. Okay, it's a atypical form of encephalitis. So those patients can have obsessive compulsive symptoms. They can have OCD comorbidly. And Tourette syndrome, it's a complex motor tic disorder. Okay, they can have brain disorder, OCD. And Sydenham chorea. I think you are familiar with rheumatic fever in children. So then they can have Sydenham chorea. So they also can have OCD. And there's a entity called PANDAS. So pediatric autoimmune neuropsychiatric disorder, like streptococcal infection associated sort of a disorder. So those people can have those, especially in children, so they can have this OCD. Comorbid. So then these can come as your MCQs. I have to go through and see whether it has come in the previous. So, but they can be given. So brain structural changes can contribute to this etiology and serotonergic function. And then they are talking about the psychoanalytic theories. I don't know whether you are familiar with Freud and Freud's theories. So he says the regression to anal stage. Okay, there are 5 stages. This might be too much for you. Like I will roughly mention like oral, anal, and the phallic, latent, and genital stages. So what Freud told was that regression to anal stage. So they will stuck in this anal stage. So then they can have OCD. So true or false, sometimes they can give this. Just remember, okay? Then there are cognitive theories because there will be a lot of cognitive processes in OCD, like wise thought, action, fusion. That means like having these thoughts that they will think this they will do it, kind of. Okay. So then responsibility. So they will think that I'm responsible if something happens to my family member. Suppose, as I mentioned, the doubts, they are getting obsessional doubts. So I am responsible if I do not perform this compulsion. So responsibility, compulsion, safety-seeking behavior, overestimation. Just remember these names in case you got an MCQ. Okay. So, and intolerance of uncertainty. They can't can't tolerate the uncertainty, whether it will happen or not, like they can't tolerate. Okay. So need for control, like they want to get control over their mind, but they are failing repeatedly. Okay, so these kind of cognitive processes will be there. Just remember for the MCQ point of view. Okay. So then this is also, I think, favorite MCQ point, defense mechanisms in OCD. Okay. So there are defense mechanisms which are unconscious, like unconscious coping methods, kind of. Okay. That also described by Freud. So he has mentioned this reaction formation, isolation of affect, undoing. These defense mechanisms can be seen in OCD. Okay, so just jot down and just remember. In the case of MCQ, you can mark these things. Okay, otherwise, like, don't go and read about it like thoroughly, because it is too much for you. Okay, then up to now, do you have any questions? Up to now, are you clear? I have 2 chats. Let me see. Yeah, somebody is asking, can you explain again about ego dystonic? Kylie. Okay, because she was asking, I will tell you. The ego dystonic means, like, it's suppose that you are a very religious person. Okay, so then you are getting recurrent thoughts about, as I mentioned, I will get that example, like harming or the destroying Buddha statues. So you are being very religious person, you are getting thought of destroying Buddha statues. So that means, like, it will, so then you will be in severe distress, because in your beliefs, you know it's a sin. So then, but you are getting these thoughts. So very distressing. Okay, so it's not keeping with your beliefs. The thoughts that you are getting are not keeping with your beliefs. So then we call it as ego dystonic. So the other thing is ego syntonic. Okay, ego dystonic and ego syntonic. OCD, ego dystonic. Ego syntonic means the thoughts that you are getting are in keeping with your belief system. Suppose, as an example, when we get a schizophrenic patient, if he believes, like if he is getting a thought that the neighborhood people are trying to harm him, so it's in his belief system, with his disease, schizophrenia. So then he thinks that is a real thing that is happening. Okay, so that's real to him. So then he won't be distressed, like he will have the distress that they will do something, but it's keeping with his belief system at that point. So it will be ego syntonic to him. Okay, then let's move to prognosis. Okay, so in these OCD patients, so it says like 2/3 will improve to some extent by the end of 1 year of the disease course. Okay, if lasting more than 1 year, so they will have fluctuating course. That means, like, they will get symptoms at times, and again they will resolve. Again they will get the symptoms likewise, or they will have a chronic course. It means throughout the life they will have symptoms. Okay, so the good news is, like, 2/3 will improve to some extent. Okay, there are good prognostic factors and poor prognostic factors. So in good prognostic factors, if there's a precipitating event present, okay, it will be a good prognostic factor. It means like suppose that you get that thought in as a case in my case scenario, like the contaminated with germs after he was exposed to some dust or mud or something after he was falling into a mud pit or something. So then afterwards he was started to getting these thoughts, then it will be a good prognostic factor because there had been a precipitating event for the symptoms. Okay. So then if there's a good social and occupational adjustment before the onset of symptoms, before he was getting this OCD, he was a person who is usually adapting to new situations. Okay, then it will be a good prognostic factors. And if the symptoms are episodic, like it comes and resolves by tones and again comes and resolves rather than persisting throughout, okay, that will be a good prognostic factor. So then there will be poor prognostic factors. So, okay, these are the poor prognostic factors. Childhood onset. Okay, my patient was about 14 years, 13 years when he was symptoms. No, it's a childhood onset. So then, comorbid personality disorder. Like, there are personality disorders you will learn in future lectures, like like an ancastic personality disorder or the obsessive personality disorder, where they need to be very neat, tidy, okay, kind of very rigid persons. So these kind of people, they will have poor prognostic factors. And if it is a male gender is a poor prognostic factor. Okay. So I told you that one in my previous slide. So there was something childhood onset more common in males. No. So here, because childhood onset one will be poor prognostic factor as well as male gender. So then tic-related forms of OCD, Tourette syndrome, okay, also tic-related form. So they will have poor prognostic factors. And comorbid depression. If the patient is having depression, OCD plus depression, so then it will be a poor prognostic factor. That means like the OCD is that much severe that the patient got depressed because of the symptoms. Okay. So up to now we have discussed up to prognosis. Are there any questions? Are there any burning questions? You can ask me because my video is not working. I think it's a kind of a disadvantage also for you because you can't see me. So are there any questions or are you clear? Or it's too much for you? You can give any comment. Okay. Because ultimately the one who are learning will be you. Okay. Shall I move to the next part of the lecture? Or do you have any questions? Okay. Silence means no questions. You have understood. Okay. So let's move to management. Okay. So the very important part of the management will be psychoeducation. Okay. When you get a OCD patient, so you have to educate about the condition to the patient. You have to ask how much you know. Some people will know in and out about OCD. They will read. Okay. So then, so you have to ask what extent that you know, and then you have to give, you have to explain about the condition. Okay. How this occurs, like roughly the things that I have mentioned, like etiology kind of things, and then about the management options. Okay. So then in the management, apart from psychoeducation, Then we have this pharmacological management and non-pharmacological management. Okay. So it says the first line treatment, the pharmacological ones would be and serotonin reuptake inhibitors. Okay. And non-pharmacological, it will be CBT, cognitive behavior therapy. Okay. Serotonin reuptake inhibitors means like I hope that you have heard about this. These are mostly antidepressants. Okay. Sertraline, okay, clomipramine, TCA, SSRI, TCA. I don't know whether you have heard or not. Like probably you have heard when you are doing psychiatry in your finals, like in your undergraduate level. So these can be used. Okay. Then they are equally effective most of the time, these serotonin reuptake inhibitors. So then the TCA or the clomipramine are more effective than the others, like more than the serotonin reuptake inhibitors. But the problem is this TCA will have anticholinergic side effects. So it limits use as first line. So usually what we use is SSRIs like sertraline. Okay. So then if it is failed, only we are thinking about changing to other antidepressants or clomipramine, combining with clomipramine. Okay. So then choice of medication will depend on the side effect profile. The TCAs will have worse like side effect profile, kind of constipation, like anticholinergic side effects, blurred vision and all. So then if there are comorbid conditions, so we have to think about it as well when we are selecting a medication. So the thing is, in OCD, unlike like depression, they will need higher doses. Okay. Fluoxetine, usually depression we start with 20 now. So then these people, OCD, they might need higher doses like 40, 60, okay. So may need combination of medication. So they might not respond to one treatment. So we might have to combine with other medications like antipsychotic low doses, okay. So you will learn if you are not familiar, like in future lectures about these medications. So that's about pharmacological treatment. So then non-pharmacological treatment. So what we use is that a form of a CBT, exposure and response prevention. So this can be used as first line as well. Suppose that the patient prefers not to take medications. So if symptoms are not that severe, okay, so not comorbid with depression, so then we can actually try this non-pharmacological treatment, exposure and response prevention as a first treatment, okay, or we can combine with medications as well. So they say either alone or combination, it reduces the chances of relapse. So the recurrences. Okay. Then if you are familiar with exposure and response prevention, you may have heard about this. So what we are doing in exposure and response prevention, patients are exposed repeatedly to the source of their obsession. So we let them have this obsession repeatedly, and what we do is we prevent from performing rituals. In the case scenario, the compulsion was repeated hand washing, and he was bathing in the bathroom for 2 hours. So we first select one of those, like we can't handle everything first all together. So then suppose that we take repeated hand washing. So then we'll ask him to cut down the times, either cutting down the time of washing hand from 3 times, when he was comfortable with washing 3 times, then we ask him to reduce it to 2 times in next time, kind of like we gradually reduce it. Okay, what we are reducing is the compulsion. Not then in turn, the obsession will reduce because So there's a curve, like I couldn't actually include it there. So the anxiety, when they are getting an obsession, the anxiety level will rise. Okay. At one point, it will become 100%, the anxiety level. Okay. If we given a mark. So then, even though they do not perform the compulsion or the ritual, the anxiety will go away. Okay. But the thing is, these patients are very much distressed with this obsession. Okay. Then they will perform the ritual before the anxiety goes away. So they don't wait until the anxiety goes off by itself. So they perform the ritual. Okay. So what we are doing is stopping the ritual. So let them be with the obsessive thought until the distress goes off naturally. Okay. Can you get my point? So that's roughly what we do. Okay. Then with time, anxiety level with the obsession will goes down, as well as the frequency of obsessions will also go down. At one point, this may take some time, some might take few months or few weeks. So then obsession will stop by its own. Okay. So that's the target. So we call it habituation. So we like leave them with the obsession. Okay, habitualize it. So then it will go away. Okay. So that's about exposure and response prevention. So that's very effective method. So I personally have tried it, and it's magical kind of. It's working, but the patient has to engage. Okay, do it. So psychotherapist, ideally the clinical psychologist should do this. Like they are the people who are doing this, because we are very busy with other works and all. But this is very positive, the results. Okay, so the other non-pharmacological treatment would be dynamic psychotherapy, neurosurgery, deep brain stimulation. Okay, there are other non-pharmacological treatments which we usually do not perform in our setup, but in other countries, they use these modalities. Okay, so this is about obsessive compulsive disorder. So do you have any questions up to now? I don't see anything in the chat as well. So do you have any questions? Understood? You can tell anything, like, is it too much?
Understood, ma'am.
Understood, no? Because I don't know about your background knowledge, like how is your knowledge one by one, I don't know. So it might be differs. Okay. So then it might be little too much for somebody. Somebody already knew those. Actually, I don't know personally. So then I can improve myself. Next time, if you give me your feedback, so feel free to tell anything. Okay. So then we can together improve. Yes. Okay. So then, as you mentioned that you understood, I'm happy if you have understood. Okay. So then let's move to the next part. It's actually a big one. Because I have seen these things have been asked in past papers. That's why I thought of including briefly about this. So there's an entity called disorders called obsessive compulsive related disorders. Okay. So because these disorders also have somewhat similar kind of a nature in symptoms compared to this OCD. So those include body dysmorphic disorder. Have you heard about this? Because I have not included this time. It's quite a little big topic. So I didn't include it. So it's body dysmorphic disorder is if somebody is very much worrying about body part, like one of the body part has been disfigured. Suppose the nose is abnormal looks. Maybe most of the time they are focusing one part of the body, maybe the mouth, maybe the like kind of, as I mentioned, the nose. Okay. So they will think the arm, like it's one is big, one is small, kind of. Okay. So that also have some sort of this obsessive compulsive nature, because they get this thought that one part of the body is disfigured and they go and look in the mirror. Okay, like compulsion, they go and check. They ask somebody whether it's disfigured or not. Okay, so that's why they are included in these obsessive compulsive related disorders. Okay, so then there's another thing called olfactory reference disorder. In that, they think that they are having this smell, some thought of smell is bad smell is coming from them. Okay, so then they go and ask some people like, are you smelling badly? Okay, are you getting a bad smell from me? Okay, sort of. Then the hypochondriasis, health anxiety disorder. Am I have this sort of a illness? Am I having a malignancy? Am I having a brain tumor? Okay, so this disorder. And there's something called hoarding disorder, where they used to hoard things like newspapers, magazines. They are not throwing away, they are hoarding them. Okay, so I will be discussing a little bit about it. And then body focused repetitive behaviors, like they are biting nails, then they will bite nails and pinch themselves, kind of. So then trichotillomania, hair pulling disorder, repeatedly they get an impulse to pull their hair. Okay. So then excoriation, skin picking disorder. Okay. So those kind of disorders they have mentioned in obsessive compulsive related disorders. So then I will be discussing briefly about two disorders. I thought that they might ask MCQs. There's a possibility. So I will be discussing about hoarding disorder. So it's a typically in middle-aged or elderly person it occurs in. They are having emotional difficulty in parting or discarding possessions, no matter what their actual value. They may be not valuable, but they are keeping. They can't destroy it or discard it. So clutter of material fills up and congested in living area. So imagine a very old lady or the man keeping stuff in the living room. Okay, films and all, like sometimes we have seen. Okay, so most commonly hoarded items like newspapers, magazines, clothing. Some will hoard animals in sometimes they hoard animals as well. Okay, so then if attempts made to reduce the hoarded items, the patient gets anxious or angry. So somebody try to throw away them, they will get anxious or angry. Unlike OCD, the thoughts about hoarding are not intrusive, repetitive, or distressing. Okay, here, though they are categorized as obsessive compulsive related disorders, these thoughts are not distressing, repetitive. Okay, because then they will be doing it, no, repeatedly. So hoarding behavior not seen as senseless or inappropriate. That's how it differs from OCD. So epidemiology, lifetime prevalence 2 to 4%, familial strong genetic component, increases with age, male to female 2 to 1%, 2 to 1, association with alcohol dependence, but not with OCD. Okay, can't be seen in OCD. So management, usually difficult. CBT, pharmacology, you can use SSRI, venlafaxine like SNRI. Like in OCD, those treatment can be used. Okay, just to mention about there's this sort of a disorder, hoarding disorder. So then there's the other one, trichotillomania. It's also an obsessive compulsive related disorder. It's a recurrent hair pulling resulting in hair loss. So there will be an area in the hair where there's no hair. Okay, in the head, there's no scalp, there's no hair. So that can involve any site in the body where hair grows. scalp, eyebrows, eyelashes commonly involved. They pull those. So they get impulse to pull, they resist, but they, like OCD, they can't stop it. So the tension will increase, will get distress, and they, after pulling, they will get a relief, like OCD, okay? So they will do it. So they might chew this hair or swallow, and then causing hair balls in the stomach, which were called these trichobazoas, and because of that, risk of bowel obstruction is there. Okay. So this can occur in childhood, adolescence, or adulthood. And we can see this in more common in women. Okay, I have seen this about last 1 month. I have seen several. Okay, it's not that rare. Often comorbid with mood and anxiety disorders and substance misuse. Just to remember, I have included this. Okay, so what happened? Wait. Okay, so then management, psychological therapies, behavioral therapies like habit reversal. So what we say is when their hand is go towards the hair, so we ask them to keep the hand tightly to the back, like keep it there, held it against the back kind of. So then they will not pull it until their anxiety goes away. Okay, so medications. So there's evidence for clomipramine, TCA. So this is just for you to like remember there are these obsessive compulsive related disorders. If they ask sort of any MCQ with that, so then you can remember this. So that's why I have included hoarding disorder as well as trichotillomania. But the other disorders, like you have to know just there are these disorders like body dysmorphic disorder, olfactory reference. If they make an MCQ, what are the obsessive compulsive what is true or false regarding obsessive compulsive related disorders, they might include one of these and they will ask. So then you have to know what are those. So just remember these. And okay. So when we are doing paper classes, so we'll discuss more about these if we encounter questions. Okay. So do you have any questions up to now? So, okay. This is the actual end of the lecture. So do you have any questions you can ask? Any MCQs if you have encounters regarding this topic, you can ask. Okay. If you are not clear with any part of the lecture, you can ask. Or your suggestions to improve, or what do you want? Because I don't know what do you actually want. Okay, I saw that most of the people were asking about questions like past papers. Can we do past papers? You have voted for that. Yeah, that's really important, I also think. So you can message or just open up and ask. No one will criticize you because this is a learning. We interactive, it should be interactive learning, then you will learn more and you will remember more. So I hope that you will ask questions, discuss about if you want to clarify anything. Otherwise, I am the only person who is talking. Are there any questions? Just to know, when is your exam? Are you sitting for this time? Are you planning to, all of you are planning to sit for this, I think, May exam? Yes. Yeah. Somebody
Yes,
message
ma'am.
that. Yes. No. Okay. OC related disorders also come as DD of OCD. Obsessive compulsive related disorders. You have to actually like, it's a kind of a separated, like not that separate, but yeah, you have to think about, yes. Good question actually. When you are having a obsessive like OCD patient, you have to ask about these other OCD related symptoms as well, like disorders. You have to exclude whether they are having any dysmorphic ideas like body dysmorphic disorder features. Okay. Any other impulse control that I have told, that other anxiety disorders and this trichotillomania, any other kind of, you have to ask actually and exclude. You have on second week of May. Okay. About less 3 months, no, 2 months. Okay. It's nearly 2 months. Less than 2 months actually. So we can add case discussions and some MCQs. Yes. Yes. We are planning to do actually paper. I think there will be paper classes in near future. So yeah. And case discussions like OSCE, we have to prepare you for the OSCEs as well. So then we will be discussing about OSCEs, the possible cases in future classes. Yeah, SBA questions as well, yes. We will discuss. Because that's quite new to you. Have you like had SBA questions, single best answer questions for your finals? No. Okay, so that might be new to you, no? Most of you?
Yeah.
Okay. So you are not that familiar with pharmacology, am I right? Most of you are not familiar with pharmacology, that I have been talking about SSRIs, SNRIs, TCS, okay, some names I have given. Are you familiar or not? So then in next lectures, I can talk bit more about pharmacology, like the main medications that we use. So if you are not familiar with them. So today I have been talking about this SSRI, selective serotonin reuptake inhibitors. Okay, so there are antidepressants like in OCD, what we mainly use, as I mentioned, as antidepressants as first line medication. So antidepressants, there are several classes. So one is selective serotonin reuptake inhibitors or SSRI. I think you have heard this sertraline, fluoxetine, citalopram, paroxetine. So there are 5 medications which falls under this SSRIs, selective serotonin reuptake inhibitors. Okay. So Usually we use those as first line in, usually the sertraline is the one in OCD that we are using as first line. So then there are SNRI selective norepinephrine reuptake inhibitors like venlafaxine. Okay. So then there are other antidepressants like mirtazapine, okay, bupropion. There are a lot of antidepressants. Okay, but usually we use in OCD are SSRIs, usually the sertraline. Okay, you can use fluoxetine and other medications as well. So then the TCA, like there's other antidepressant class called tricyclic antidepressants, TCAs. Okay, clomipramine, which is used in OCD, okay, is falling under the category of TCA, tricyclic antidepressant. Okay, clomipramine. So that has a lot of side effects. Anticholinergic side effects, we say, like constipation, urinary retention, blurring of vision. Okay, so it lowers seizure threshold. So a lot of side effects. So that's why we are not using as first line. Okay, comparatively, this compared to this TCA or the TCA tricyclic antidepressant, which the clomipramine belongs to. So compared to that, these SSRI or the selective serotonin reuptake inhibitors will have less side effects. So that's why we are using as them as first line medication. Okay, I think that you will be clear. Like, so if you hear these, like if you have not heard these terms and all, like it might be difficult for you. So we will little, like in our next lectures, we will discuss little more when I will include them. Then it will be easier for you. Ne? Okay, thank you so much. Like we can wind up for today. We will get written feedback.